Hello, this is Amber Mounty. I'm an emergency physician at McKay Hospital. Presenting this case was Steve Sharman, who is a team physician at Weber State University, in addition to being the assistant residency director for our family practice program. We represent McKay Orthopedics and Sports Medicine in Ogden, Utah, as part of Intermountain Healthcare. Our case today involves palpitations in the elite endurance athlete. Our case involves a 43-year-old female elite endurance athlete that presented to the clinic with complaint of frequent palpitations. She describes several episodes of near syncope at the start of several races, including most recently at the beginning of a triathlon at an altitude of 7,600 feet in 65-degree water, in addition to a Nordic marathon start at 8,500 feet later in the year in cold weather. She also describes several prolonged episodes of palpitations, one of which lasted about 1 hour after getting dehydrated on a long road cycling ride in the summer. Another, which lasted about 20 minutes, also in the summer, was during a mountain bike ride that involved several thousand feet of climbing. Her initial physical exam and cardiac exam were normal, with no evidence of murmurs. She did have an initial EKG, which demonstrated signs of bradycardia with a heart rate of 45. This EKG did demonstrate ST segment elevation with T-wave inversions noted in V1 through V3. Initial labs demonstrated a normal comprehensive metabolic panel, complete blood count, thyroid panel, urinalysis, 24-hour urine cholesterol panel, and pregnancy tests, which were normal. Her initial echocardiogram demonstrated increased left ventricular volume and elevated left ventricular end diastolic pressure. She then underwent an event monitor for 2 weeks. The report is below. There were no concerning arrhythmias noted during moderate activity. She did, however, have frequent supraventricular tachycardia, primarily atrial tachycardia, which is noted at rest, in addition to one episode of non-sustained ventricular tachycardia, which lasted 11 seconds. This ventricular tachycardia was noted to be polymorphic and quite fast at 190 beats per minute. The frequent atrial tachycardia was also noted to have some pauses afterwards, which were during episodes of increased vagal tone, particularly at rest, during sleep, and eating. Pauses were noted to be up to 2.4 seconds, with a minimum heart rate noted on event monitor of 33. She then underwent a stress test, which was noted to be standard Bruce protocol. There were frequent PVCs in addition to short runs of supraventricular tachycardia, which were noted below. This test was stopped at 13 minutes due to elevated blood pressure. Her maximum blood pressure was 240/87 during the test, with a heart rate of only 157, which was considered in the moderate range. She had a post-test blood pressure that was only 145/82. She then was encouraged to do a 2-week blood pressure log with an average of 123/74. A cardiac MRI was obtained, which demonstrated increased left ventricular volume with a normal ejection fraction consistent with echocardiogram results. She was noted to have a normal right ventricular size and function. She did, however, have bilateral atrial fibrosis, which was noted to be greater on the right than the left. She did not have any evidence of left or right ventricular myocardial fibrosis. Another stress test was obtained at 6 months after she had been started on losartan 50 milligrams daily. This was again standard Bruce protocol with a time maximally of 18 minutes. She obtained a maximum heart rate of 165, though her max was estimated for her age to be 176. Blood pressure at the time was noted to be 204/76. She did have frequent premature ventricular contractions, which were noted below. There was thought to be some evidence of sinus node dysfunction, which was theorized by electrophysiology to be related to the atrial scarring. She was also noted to have right ventricular tubercular thickening, which was noted on the echocardiogram. Therefore, diagnosis was thought to be initially athlete's heart syndrome, which involved the sinus bradycardia, non-sustained ventricular tachycardia, and the frequent premature ventricular contractions and premature atrial contractions. She also had a component of exercise-induced cardiomyopathy, which was demonstrated by the fibrosis of both atria, which is likely permanent and may contribute to an increased risk over time of atrial arrhythmias, as seen by the frequent atrial tachycardia. She also demonstrated exertional hypertension, which may have continued to be undiagnosed in this athlete without a stress test, but is considered pathologic due to the amount of left atrial fibrosis demonstrated on cardiac MR. She was referred to cardiology and electrophysiology, who assisted with the workup. She had an implanted loop recorder for long-term monitoring. She was started initially on losartan 50 milligrams, but then aldactone 25 milligrams was added after the subsequent repeat stress test, in addition to flecitine 100 milligrams daily. Ablation will be considered if she has prolonged or recurring symptomatic arrhythmia, as demonstrated on the loop recorder. If she does have persistent ventricular arrhythmias, this will warrant an electrophysiologic study and potential defibrillator. She did ultimately decide to engage in indefinite detraining, which included retiring from elite competitive racing, in addition to engaging in low to moderate activity only, which was thought to be in the range of 130 to 150 beats per minute, which is sublactate threshold for her. So far, she has had no reoccurrence of prolonged arrhythmias to date. Thanks for the opportunity to present this case and discuss what I feel is an evolving topic in sports medicine and cardiology as more people participate in these events. Please direct any questions that you may have on the discussion board or email me directly. Thanks again on behalf of McCady Sports Medicine and Intermountain Healthcare.